I will talk about the interruption of vaccination programs at the country level and the strategies that countries use to close the immunity gap. Immunization programs were widely disrupted due to COVID-19, especially 3 to 4 months into the pandemic in May. This situation was much more prominent. At that time, trying to understand the situation at the country level, immunization partners such as WHO, UNICEF, Gavi, and a couple of other partners conducted what we called immunization pulse polls. These were circulated to the countries and responded by the immunization stakeholders on the ground, including the government focal points and the partner agency focal points. 82 countries and 200 to 260 respondents responded, both from the national and subnational levels. Of course, the results of this survey is not representative and only shows the subjective perceptions of the participants to the survey. Nevertheless, it provided valuable information at that time where very limited information was available. As you see, most countries reported disruptions, especially to the fixed post and outreach immunization services. 3 out of 4 countries expressed disruptions completely or partially. And all the scheduled campaigns at that time were suspended in line with the technical guidance from the partners. Outreach activities were more impacted than the fixed sites, particularly in the African region and the Americas. And fixed post immunizations were reported as disrupted, particularly in Southeast Asia and Asia, possibly due to lockdowns, and the region of the Americas. But we have to say that this was in May. As you remember, afterwards, starting in June, African countries also started to experience widespread lockdowns. So the situation has changed some. The reasons for disrupted services varied. There were a group of reasons related with service provision. Many health workers were unavailable because of restrictions on travel, or they were being redeployed for COVID response duties. There was also a lack of personal protective equipment, discouraged many health workers going to the health facilities and reporting to work. In addition, supply shipments were also disrupted throughout the world, especially the supply shipments from UNICEF supply division, vaccines and immunization supply syringes, due to flight cancellations and lack of cargo space. And this situation lasted for several months. There were the other group of reasons related with access. Even when services were offered, people were unable to access them because of reluctance to leave their homes, transport interruptions, the economic hardships, loss of income, restrictions on their movement due to lockdowns, or just fear of being exposed to COVID-19 virus outside. The lack of personal protective equipment was more prominent in Africa and the Middle East, and lockdowns was a more prominent reason in the Southeast Asia. Then, as discussed just before this session, widespread school closures had been a further disrupting factor, especially on HPV vaccine delivery. School platform has great importance in HPV vaccine. Probably Paul previously talked about that. Remember that WHO analysis indicates that 76% of countries implementing HPV vaccine either use school-only or mixed school health facility-based delivery strategies. So when the schools are closed, 3 out of 4 countries in the world experience disruptions in their HPV vaccine delivery. And at the peak of the COVID-19 lockdowns, schools were shuttered for more than 90% of the world's students' population. And as you know well, the situation still hasn't resolved. Most schools are not reopened. Today, 875 million of students remain affected from that situation. Immediately after the start of the pandemic, UN agencies and other immunization partners started with high-level advocacy for the reinstating essential health services, including routine immunization services, including HPV, of course, restarting outreach activities and catch-up campaigns whenever the situation allowed, and also reopening schools as soon as possible. There were press releases, calls, and these were intensified after 3 months when it was evident that the effects of the COVID pandemic would be widespread and long-lasting. Also, many technical guidelines were issued on preparedness, continuity, and reopening of services. I guess these were also covered in a previous presentation in that meeting, but I'm showing here just a selection of the many in the list. There's one very recently updated regarding immunization as an essential health service and the guiding principles to restore immunization activities during the pandemic. There's community-based healthcare, including outreach and campaigns, practical guidance at the community level from the 3 agencies. Then there's a specific PowerPoint on closing the immunization gaps caused by COVID-19, which is relevant for most of the countries. There's also the framework for safe reopening of schools in the COVID context to further encourage governments which are hesitant to reopen schools to do this in a safe way and to enable children both access to their education, which is so crucial for them, but also school-based health services such as HPV vaccination. So how did the countries respond to these challenges and employed alternative strategies to deliver HPV vaccine? This is, of course, a challenge and still going on. There is, I think, no country which managed to resume the HPV vaccination as it is before the pandemic levels. But at this part, I would like to provide 3 examples from the countries that we are familiar with on the utilization of different delivery strategies. Myanmar introduced HPV actually very recently in the context of the pandemic. The country was ready to introduce, it conducted the HPV readiness assessment, as we call it, in advance, a field assessment, just evaluating the readiness of different levels and different work streams. It was found that more than 90% of the structures were ready to introduce the vaccine at all levels. Despite that, the launch date was postponed a couple of times because the schools were closed and there were uncertainty on which strategy to employ. Finally, the government decided to launch the vaccine and did so in October. There was very high level commitment and stakeholder support. The country decided to change its delivery strategy from school-based to community-based. Only for this year for now, but I guess they will look into the situation next year. Because they have been implementing the first dose this year, next year the same girls may receive the vaccine either in school or health facilities and communities, depending on the evolution of the pandemic. They are also going for a phased implementation. They have started in districts which does not experience any lockdowns, and leaving the districts under lockdowns later in the implementation. They are also implementing social distancing and infection prevention measures. And the challenges they report are with human resource availability due to COVID response and conflicting priorities, but also challenges with the communication and social mobilization activities at the field level, which some of those highly dependent on face-to-face communication. So the second country example is from Uganda. Uganda started HPV vaccination back in 2016, but the program has proceeded with rather weak coverage and with very low coverage. Despite that, the important point is that the country continued to conduct what they call integrated child health days twice a year. These are conducted in April and October with the aim of reaching every child and woman with essential health services, including immunization. And the country continued to conduct two of these child health days in April and October this year within the COVID context. HPV vaccine continues to be part of this package offered to adolescent girls. These activities complement routine immunization services. Also includes catch-up immunization for children or adolescent girls who is not vaccinated before during the routine. And they use health facility-based delivery plus community outreach delivery strategy during those child health days. Of course, employing social distancing, hand washing, and personal protective equipment. But this shows the commitment of the country to continue with routine immunization and also include the HPV vaccine through those activities, and is also an opportunity to reinforce community awareness and social mobilization through to face-to-face contacts with the communities and community leaders during those activities, and the opportunity to provide messages about the immunization strategy. My last example is from Kenya. Kenya introduced HPV vaccine in October 2019, last year, with a health facility-based strategy mainly, but supplemented by school and community outreach strategies. After 6 months, in March this year, the country was supported to deliver the second dose of HPV vaccine, just at that time when the first COVID-19 cases were confirmed in the country. So this graph actually shows that the number of HPV-1 doses administered to the girls before the pandemic started, due to school closures for winter break, and when the first COVID-19 cases were announced. And after that, as you can see, the coverage dropped to very low levels, also due to the school closures. The challenges experienced during that time was initial cancellation of all outreach activities. There was also confusion in the EPI program whether HPV vaccination was considered as an essential service as per the technical guidelines issued by WHO. Then school closures resulting in reduced vaccination opportunities, although their primary delivery strategy were not schools, they were using schools as a platform. Then the restricted movements of the population increased public transport costs, and redeployment of health staff to COVID-19 response. Also, the avoidance of health facilities by the caregivers for fear of contracting with the virus, and also, as discussed in the previous session, rumors circulating about the HPV
We're running
vaccines
very
and
much
other
over
methods.
time. Will you be much longer?
Yes, I'll just wrap up in the couple of slides. Then there was good practices from Kenya. It was the opportunity to track girls from the health facility registers, also their community health workers following up the eligible girls. Sensitization provided to the village elders, and girls were also encouraged to inform and bring their friends to the immunization sessions. As conclusion, HPV vaccination has been severely disrupted during COVID-19. Although programs are now being resumed, it will take time for services to reach pre-pandemic levels and close the immunity gaps. The national immunization programs are still under pressure to respond to the pandemic, and also they are intensively preparing for COVID-19 vaccine delivery. And the biggest challenge is reaching marginalized and vulnerable populations during that time who has less access to services. There are a number of strategies countries can adopt to improve HPV coverage and close the immunity gap, although this is more challenging in practice. And the comprehensive technical guidance is available from all partners, but funding, human resources, and conflicting health priorities remain as issues. Thank you very much.